Welcome back to the discussion, The Role of Family Caregivers in the Healthcare System, sponsored by AARP and WTOP.com. My guests today on our panel are John Poole, a former family caregiver and caregiver advocate, Dr. Meena Seshamani, Director of the Center for Medicare at the Centers for Medicare and Medicaid Services, Dr. Benjamin Powers, a surgical oncologist at University of Maryland Capital Region Health, and Nancy Lamond, the Chief Advocacy and Engagement Officer for AARP. Well, let's pick up on our discussion. John Poole, as we mentioned, you have been on the front lines of so many of these issues, and you touched on some of the very many difficulties that caregivers like yourself have faced. Having talked about some of those challenges, what are some of the things that you would like to see or things that would have helped you in your personal experience as you dealt with so many challenges?
Well, I think if caregivers were treated as individuals more often by the healthcare and insurance systems, that would be of great help to many people. And I'm glad that more attention is being paid to that need to happen in regards to different legislation and just more discourse taking place around this subject. During my time as a caregiver, I felt like I was being treated with a one-size-fits-all approach, which was not that helpful to me because I was, at the time all this happened when my parents had the strokes. I was 30 years old and in the workforce while working full-time, and I had to sidetrack all of that to manage my parents' care. I don't regret that decision because it was necessary at the time. And I felt that because of some of the miscommunication that was experienced early on, that they would receive better care if I had a more active role.
Talk to us a little bit about the personal toll that takes on you as a caregiver, someone who is in their 30s, dealing with a full-time job. You know, your career is, probably just starting to take off, and you're dealing with a whole nother set of what was really the most important job that you had.
Yes, it was very scary and intense in the very beginning. It was a learn as you go process where just some things arise and you don't expect them. You don't expect them, so you really don't have a strategy plotted. And then there's no infrastructure for you to go to, especially someone in my position. I feel like the healthcare system and policymakers often forget that there are many younger people dealing with this. I'm happy that Ms. Lamont cited that statistic about how many millennials are providing care for their parents, because this is an issue where there's a lot of overlap, but each person's story is different and they should be treated accordingly. And maybe if the healthcare providers and case managers upon creating discharge plans, if they were to ask the people what they needed help with most, like mine would be, of course, maintaining ties to or reentering the workforce, because at that point in my life, I wasn't in a position where I could just take time out of work and not have it impact me negatively. Most apparently in the my opportunities for professional advancement and the ability for retirement seat.
So, did you feel like you had, obviously other than your family, did you have anyone either institutionally or elsewhere that you could lean on? I mean, it seems like for someone who's in a tough position like yours, it would be, you feel like almost like you're out on an island. Were there any support mechanisms that helped you?
Yes, there were a few people here and there in the healthcare system. I don't mean to dismiss the work of the people I interacted with. I just feel it could have been enhanced to a greater degree. I did have help from family. The people who I did ask questions of in the healthcare system were receptive. But one example is when I was learning how to administer my mom's feedings and medications through the PEG tube, that there was a formal training. It was one of the nurses who dealt with her. She gave me maybe about 15 minutes of training. Luckily, I picked it up quickly enough, but I just thought it would have been better for myself and other people in this position who have to manage medical tests that they're not trained for officially, if there was some kind of official formal training that they received. And one of the barriers I felt when you mentioned institutions who provide information for people in my position, a lot of times I will call certain places and there will be no answer, which I understand, but sometimes the organization's voicemail was full. And I contacted a local senior services office and was told about information for family caregivers and was told that their only obligation was to determine a person's eligibility for Medicaid, which I understand the need for that role, but I just think the need for people in my position, family caregivers, to have an institution or organization to go to where they can receive information and help that empowers them instead of just makes them dependent on an organization just doling out information as they see fit without any regard to the individual's life and what they need to do to plan for their own future and manage their loved one's care.
Well, thank you. Nancy, you've dealt with this on a policy level for many people. AARP has been very active in trying to help with several of the issues that John is talking about. I wonder if you could talk about what AARP and other advocacy groups are trying to do to get attention to some of these important issues.
Sure. Well, to begin, I think it's important to note that the caregiving experience can be very different for very different people. I call myself a serial caregiver. I started in my 30s helping my mother care for my father in New Jersey. I was living here. And then after he passed away and my mother got ill, I was pretty much a full-time long-distance caregiver for my mother. And then in 2014, my husband was diagnosed with ALS, and we cared for him, myself, a cadre of paid caregivers, and my two millennial sons in our home for 6 years before he passed away. And what struck me was how different each experience was, and the information I needed and the support was very, very different. And so at AARP around 10 years ago, we heard from all of our members how important this was. And so we've done a number of things. First, we have a very wide-ranging collection of materials to try to help people at aarp.org/caregiving. And it's to try to help anyone dealing with a range of conditions with the information they need to know, including an online support group that when we started had a few people and now has thousands who engage regularly. Second, we began our advocacy, interestingly, more actively at the state level. And over the years, we've seen hundreds of bills passed in every state, red, blue, purple, to help family caregivers with respite care, costs of care, home and community-based services, range of things. And now we're beginning to see action at the federal level. I know Dr. Seshamani is going to talk about some of it, but in 2018, bipartisan legislation passed the Congress to direct the Department of Health and Human Services to develop a national strategy on family caregiving. That's now in place. There are hundreds of recommendations, and we're all focused on making sure those recommendations become reality.
And Dr. Powers, going back to some of the issues also that John touched on, you have experience dealing obviously with patients individually, but I know that you've also been involved with research to try to figure out some of these things. As he indicated, he had to basically become, medically proficient in some very, very key areas with his parents.
The number of hats that caregivers have to wear is numerous, as has been clearly mentioned. I think that, obviously one of our big efforts in the University of Maryland has really been to be able to identify our patient navigators and integrate them into our clinic as closely as we possibly can. We want to, at the time even of first contact, when patients first interface with our health system, to be able to align them with case manager, social worker, and a cancer navigator to be able to help them move across the healthcare system. Because I think that, again, a lot of cancer care is multidisciplinary and patients are seeing multiple providers. And being able to navigate that is incredibly important, and having that assistance is very helpful. As Mr. Poole had mentioned as well, I think there's another area where a lot of those resources can be very beneficial for caregivers, and that is in the area of wellness and burnout. The psychosocial impact of chronic caregiving is immense. We know this. There's copious literature to support all of this. And so how then do we help with the psychosocial needs of caregivers themselves? And I think that's another area where health systems and providers can play a really major role. And then I think the third area is, while all of this is an incredible start, another area where we really, really have to focus is on that time from symptom to getting patients actually to the right providers. Because certainly within the social orbit of the patient, before even sort of the pre-caregiver phase, the social orbit that exists around patients at the time leading up to a diagnosis is very critical. We know in the U.S., roughly half of patients with esophagus, stomach, liver, and pancreatic cancer who have resectable disease never get to actually see a surgeon and be able to actually get the surgery that they need, which is potentially curative. So some of the research that I've been engaged in is working a little bit more upstream to be able to try to identify patients near that time of diagnosis, and working with community organizations and other nonprofit cancer organizations, getting those patients the education and navigation resources that they need to be able to identify centers who can treat them. And so one of our big pushes, certainly at the University of Maryland and at Capital Region Health, as we create our cancer center there in Prince George's County, is to really try to be forward-thinking and modern in our approach to starting to treat cancer patients in Prince George's County.
And jumping back to the Washington element of all of this, as Nancy pointed out, it started in many respects in the states, as it often does with policy. But can you talk a little bit about what is happening now at the federal level, as maybe Washington, as it often happens to be, catches up to a lot of these issues?
Yeah, absolutely. So piggybacking off of the prior, discussion we were having, there are kind of three main buckets. The first being, as we talked about, where we are really streamlining a lot of that prior authorization, additional information needed to see if a health plan would cover, treatment, because we want to make sure that people can get access to medically necessary treatment and get access to it in a way that is streamlined and is not creating burden on people who are already burdened, like caregivers. That second bucket around marketing, especially during open enrollment time, where we're really cracking down on misleading marketing practices so that we can make sure that caregivers are able to help their loved ones navigate, and figure out what option is going to be best for their health and financial situation. And then that third bucket on how do we, using our Medicare payment levers, best support, caregivers. And I think a lot of that is, to piggyback off of what we've all been talking about, really creating a health system that's wrapping its arms around people. And so this is where being able to pay for caregiver training, paying for care navigation. Also, we're now going to be paying for community health services. So, as I think John had mentioned, where everybody has individual needs, the needs of particular communities in terms of transportation and housing and food, these all play into someone's health and play into what a caregiver needs to do to care for someone. And so Medicare being able for the first time to pay for community health integrated into that broader care, I think is critical here. And then, a final point is, as you mentioned on burnout, in this, how do we create a system that's wrapping its arms around people that we're serving? We have established a program, especially in rural and underserved areas, where smaller healthcare providers can get resources up front from us to become something called an accountable care organization, where they, become this organization that will take accountability for the quality of care provided and the cost of care. Because if you keep someone healthy, you keep them out of the hospital, you're spending money in a smarter way. And we're in giving this money up front to these small providers. Some of the things that they can use that money for are respite care for caregivers, right? Like being able to just open the door a bit to let people on the ground figure out what is needed for that person and that family and that community in front of you. And again, we think that's a good bet because then people stay healthy, then they don't bounce back and forth into the emergency room, into the hospital. And, our innovation center tested this model and found that it actually saved money and improved quality, which makes sense, right? So I think these are some examples of the work that we're doing. And it's so important that we're having conversations like this because, for example, John, hearing your story, these are the kinds of things that we need to hear from everyone about so we can figure out what can we do to help, knowing that it's not just Washington, right? To what I was saying, it's how care plays out on the ground. It's really partnering with patients, with communities, with providers, with health plans, because ultimately we all have a shared goal of improving the health of our populations, and we all have to work together on it.
Well, I think that's a good note to end on for our second segment. And we'll be looking forward to what is being done. What are some of the solutions, some of the areas of optimism that we might have in dealing with this very challenging issue?